Hello, and thank you for standing by. Welcome to the AGD webinar, Basic Extraction Techniques and Predictable Socket Grafting for Eventual Dental Implant Placement with Dr. Bart Silverman. During this presentation, participants are in a listen-only mode. The audio portion of the webinar streams through your computer speakers. If you are having trouble hearing, please check the volume settings on your speakers. If your video or your audio is playing poorly, you might be experiencing a bandwidth issue. Please try to refresh your screen or check your internet connection. At any time during the presentation, you may text a question or comment to the speaker using the Q&A box. Our speaker will address as many questions as possible at the end of the webinar. As a PACE-approved program provider, the AGD is required to monitor attendance throughout this 1.5-hour lecture. As a reminder, this webinar provides 1.5 hours of lecture credit in AGD subject code 690 implants. You will receive your CE certificate in accordance with PACE guidelines. Tonight's webinar will be presented by Dr. Bart Silverman. Bart Silverman, DMD, graduated summa cum laude from Fairleigh Dickinson University in 1982 and received his DMD in 1986 from their School of Dental Medicine, where he was a member of, Dr. Silverman, I'm going to apologize for not pronouncing your honor society correctly, but is that Omicron Kappa Upsilon Honor Society? Did I get that correct?
That's perfect.
Perfect. He completed his oral and maxillofacial residency at Westchester County Medical Center in 1989 and was a chief resident in his final year. He is in private practice, limited to oral and maxillofacial surgery in New York City, New York. Dr. Silverman, the microphone is yours.
Oh, thank you very much, Joyce. That was so nice. A beautiful introduction. Thank you so much. And I have to say, I'm just really, truly honored to be able to be here tonight. It's a special night, and I'm honored to be able to provide a webinar for the Academy of General Dentistry. So as Joyce said, what we're going to do tonight is we're going to talk about basic extraction techniques and predictable socket grafting for eventual dental implant placement. And as Joyce graciously introduced, I'm a board-certified oral and maxillofacial surgeon, and I practice out of New City, New York. I'm also a diplomat of the American Board of Oral Implantology. I practice full-time oral surgery in our practice up here. I'm on several dental school faculties, as well as teaching many implant programs. I also have a teaching facility up here in New York, and just really love the exchange of education. So I'm truly honored to be here tonight. Thank you very much again. Just a couple of things. The opinions in this lecture are of my own, and in no way have the images been altered or manipulated. And if you see any company slides in the presentation, they're there because I chose to use them. And I'm being paid an honorarium tonight for this program, and I do consult for several companies. All right, so tonight what we're going to talk about is some extraction techniques, and we'll go through the equipment that I use in my practice. We'll talk about flap design, but more importantly, we'll start off with a discussion of surgical anatomy. Then we'll go through some fundamentals of bone grafting, and then we'll finish up with a predictable socket grafting technique, which will help generate some horizontal bone and predictably thick keratinized tissue for future dental implant placement. So welcome once again to everybody who's joining us tonight, and truly once again honored to be here. So this is my Instagram handle here. So please, if you'd like, take a couple pictures of tonight's program. You could post them online. Also, please send me a friend request and I'll follow you. You can follow me back. And I think that this is the way we can really learn from each other and exchange information. I think that's how we grow and have fun with this, with our field. All right, so what we're going to talk about tonight is we're going to talk about some extraction techniques so that hopefully they're nice and kind and not like this as we see here. Also, hopefully after tonight's webinar, truly gone are the days where we say, well, if you take enough bone off, we'll be able to get any tooth out. So we'll get started. Okay, so as an oral surgeon, you know, I always want to put things into perspective. So I went to 4 years of dental school, let's say 4 years of college, 4 years of dental school, 4 years of oral surgery program. Actually, most people do that. I did it a little shorter. So there's usually 12 years of education involved in becoming an oral surgeon, give or take. And then I always say that we have 32 teeth in the mouth, and is it safe to assume that the upper jaw is a mirror image of the lower jaw? And the answer is, of course, yes. So if we do that, then we're probably dealing with about 16 teeth. And then is it safe to assume that the left side is a mirror image of the right side? So then we're down to about 8 teeth. And then we could always say that, as far as the canine and lateral and central incisors go, that's probably one type of tooth. And then the second type of tooth, probably a first and second bicuspid, they have about one or two roots themselves. So that's a second type of tooth. And then the third different type of tooth we have is probably our molars, our first molar, second molar, third molar. So all in all, there's 3 different types of teeth. So basically, I went to 12 years of schooling to learn how to take out 3 different types of teeth. And before we start, there's one thing I just want to apologize for.
Now that Trump has tested positive and is showing some symptoms, according to the White House, although we have yet to hear from a doctor from the White House, we should note, and that is needed, a real doctor, not an oral surgeon.
So I just want to apologize being an oral surgeon, and we'll get started. So I don't know if you saw in that last video, but did you see Sanjay Gupta's eyes? As soon as the gentleman said oral surgeon, his eyes kind of opened up a little wider. But anyway, we'll start. So as we start our discussion tonight, it's really important that we start off with surgical anatomy. And I think nobody should know the surgical anatomy, the oral cavity, better than we do. And I remember taking my oldest son one time to my friend, a local physician, and I said to my friend Howie, I said, my son has a sore throat and he's been, kind of scratching and stuff. Can you take a look? So of course he says open wide, and he goes back with his tongue depressed and goes right to the back of the oropharynx. And I was like, wait. I said, you just skipped through the lips, the teeth, the tongue, and the back of the structures that I took 4 years of my life to learn about. So we can't just disregard that in 2 seconds. So we need to know the anatomy better than anybody else. So of course, when we're talking about the maxilla, the bony anatomy, we need to know the canine eminence. We need to know where the infraorbital foramen is, anterior nasal spine. If we look along the palate, we need to know the tuberosity area and the nasopalatine canal, greater and lesser palatine, foramen and vessels. We'll talk about in a second. Okay, then when we get into arterial supply, we know that the arterial supply to the maxilla comes off the external carotid, and we know that there's 3 divisions of the maxillary artery that we're particularly concerned about. The first division goes on to the brain, the second division goes on to the muscles of mastication, and the third division goes on to the maxillary maxilla as well. Our venous drainage follows our arterial supply, and everything kind of drains backwards into the external jugular vein. And as far as nerve division of the maxilla, we know that it comes off of cranial nerve number 5, more specifically the second branch or the maxillary division. And here you can see it gives off the posterior superior with anastomosis with the middle and anterior superior, as well as the infraorbital nerve. So that's our anatomy of the maxilla. And just like we have anatomy of the maxilla, we should talk about the anatomy of the mandible, where we have on the external surface, we have mental protuberances on both sides. We have the mental foramen, our external oblique line towards the posterior. And on the lingual, we have our submandibular fossa, our genial tubercles, and our mylohyoid group. So we should know this bony anatomy, once again, better than anybody out there. In addition to the bony anatomy, we have an arterial supply of the mandible, once again coming off the external carotid. And here we can see the inferior alveolar coming off that maxillary first division. We also have the facial artery and sublingual arteries that we have to deal with too on a regular basis. Okay, in addition to the bony and arterial supply of the mandible, of course, there's the nerve supply. And our nerve supply comes off of cranial nerve number 5 as well, and more specifically, the mandibular division. And we're concerned about on a daily basis our inferior alveolar nerve. And of course, this nerve can be easily damaged, whether we're making a flap or drilling a tooth or an implant. So we have to pay particular attention where that nerve is. In addition to the inferior alveolar nerve, of course, we have the lingual nerve. And the big thing here is that most of the time, the lingual nerve will lie away from the mandibular teeth. But there is a small percentage of people where that lingual nerve can ride pretty high up on the lingual surface of the mandible, and more specifically distal to that second molar. Sometimes it could lie right adjacent to that lingual bony tissue. So be very, very careful whenever you're reflecting a flap distal to the second molar, because we always expect the unexpected, that maybe that nerve is there. And of course, the lastly is the long buccal nerve, and this is a nerve that really doesn't pertain to us too much. Maybe if we're doing a block graft, but patients don't experience too much sensory deprivation if we do injure this nerve. Okay, so that's our bony anatomy, that's our arterial anatomy, our venous anatomy, and as well as our nerve supply to the maxilla and mandible. Okay, flap design. So principles of flap design is that what I like to say is that before you do anything at all, always visualize what you're going to do. So if you're going to make a flap, visualize in your mind what structures you might be associated with during that flap. If you're going to take a tooth out, you do the same. So of course, we need to know our anatomy, and that's why we spent the first part of this webinar talking about our anatomy. It's very important to know where all these bony, blood vessel, and nervous tissues lie. Okay, whenever you're designing a flap, we want to make sure that we stay away from any areas of pathology. You know, whether we see this on clinically from the patient, or we see it a radiographic evaluation, whether it's a 2D view on a PA or a Panorex or a three-dimensional cone beam scan, we need to localize the pathology and stay away from that pathology. So whenever we make vertical releasing incisions, we want to make sure that we're about roughly 6 or 8 millimeters away from that bony defect. A couple of the key points about flap design is that when you're suturing your flap, make sure you don't suture under tension, and we'll talk about that in a few seconds. Always make sure you just gently handle your flap. You don't want to tear the edges. You don't want to suction directly on the tips of the edges. You don't want to be suctioning and banging on those especially thin flaps, because we know that the areas will necrose and dehiss, and it wouldn't be good for our healing. Okay, just as an aside too, whenever we're thinking in terms of vertical releases in the maxilla, try not to make a vertical release directly over your canine eminence, as this area tends to scar, and aesthetically it's not so good. Okay, so when we design our flaps, we always want to think in terms of designing our flap with a broad base as compared to our free margins. So it's almost like trapezoidal in shape. And the purpose of this is that this can preserve an adequate blood supply to our thin free marginal tissues. Also, it helps us prevent chances of us cutting through major arterioles when making our flaps. And most importantly, when we do retract the flap, we want to make sure that our flap is on bone and not on soft tissue, that this can cause soft tissue trauma and swelling. Okay, very, very important parts of flap design. Okay, but the overall key is visibility, is good visibility. You need to see what you're doing. You can do a really good job as long as you see what you're doing. Okay, next, when we make our flaps, we want to think in terms of subperiosteal or full thickness flaps. Okay, the only time we don't consider this in doing implant dentistry is if we need to close, say, our flap over some soft tissue or a connective tissue graft, and we might do a split thickness flap. So once again, all our flaps are full thickness. We cut all the way down, go down to the bone, include our periosteum into the flap that we are reflecting, full thickness. Okay, most importantly, we want to take our time. You know, don't tear the flaps, just be very, very gentle to those flaps. They'll heal faster, less swelling and less discomfort for our patients. Okay, when we talk about flap design, we would be remiss if we didn't talk about complications of a poor flap design. And we know that maybe if we're not gentle to the flap as well, we can get flap dehiscence, we can get flap necrosis, we can get tearings of the flap. And of course, what we want to try to avoid is injury to any surrounding structures. Okay, so let's get started now with our extractions. A basic surgical setup. So what we do in our practice is that we have a basic surgical setup, and we have about anywhere from 9, 10, 12, 13 instruments. It's just a basic setup. We put it into a sterilization pack or a cassette. We sterilize these instruments together. This is our basic surgical setup. Patient comes in for surgery, open up the setup, put it on a sterile drape. Everything is kind of in place. We typically will go with, we have a syringe with a needle and a local anesthetic. We'll put a blade handle and a blade out. We put a periosteal elevator, and we'll talk about all the uses of most of these particular instruments. We'll put out a Selden retractor, a tongue retractor, and a straight elevator, and forceps, a needle holder, suture, and some gauze. What we like to do, in addition to the basic surgical setup, is just add any particular elevators that we need for whatever particular tooth we're taking out, and maybe a couple of extra forceps as well. Okay, we just want to keep it simple. Patient comes in, open up your basic surgical setup, set everything up, add your appropriate elevators and forceps for the particular teeth. Scalpels. In our practice, we like a number 15 blade. What you can do is you can get a sterilizable blade handle and just get a disposable number 15 blade. It's easy to set up. Or some people buy just a disposable blade and scalpel handle as well. Single use, and then of course throw it out in medical waste. How do you hold a scalpel? Well, we recommend a pen grasp. Just hold it like a pen. You don't want to clutch it so strongly in your hand like you're gripping an axe and you're like an axe murderer from a Psycho movie or so. Just hold it very, very gently. Have full control like a pen, like you're holding a pen. Okay, we like a periosteal elevator, and of course, I like a molt periosteal elevator. So on one side, it's a sharp pointed end, and I use this pointed end to gently reflect my papilla, and I'll show you my technique in a few minutes. On the other end, it's a broader, flat, rounded end, and I use this once I lift up my attached gingival tissues and my papilla. I'll probably switch to the circular end, the broader end, and just elevate the rest of the alveolar tissues with that. Once again, placing on bone and just lifting up periosteal tissues superiorly to us. Okay, instruments for retracting soft tissue. Very, very important to talk about this as well. So there are about 2 or 3 really, really good ones on the market. Minnesota retractors are great to hold the tissues out. We find most of the younger doctors that are coming into practice are pretty much trained with Minnesota retractors. Selden retractors are kind of nice if you want to elevate a flap that you're working on, whether you're taking out a tooth or doing a bone grafting procedure. These tend to be the 2 most common retractors. We also recommend a Catania retractor. We find most of the older doctors, like myself, we like a Catania retractor to hold it's like a right angle retractor. If you're looking at the picture right now on your computer screen, it's the one on the left, a picture of the patient's mouth, and it's the particular retractor on the lower left-hand side. It's a right angle retractor. And this is great for holding out the cheek when you're giving local anesthesia or starting to elevate the tissues of the teeth. On the right side of your screen, you'll see the tongue retractor, and you can see that tongue retractor is placed gently against the throat pack. So we always recommend a throat pack, and what I like is I like a 4x4 gauze. I like to open it up once, fold just that 1/2 in half, and then that half again in half again. And what we do is you can see that final half that we folded twice, we place that up against the tongue, making a throat curtain over the oral pharynx, and we use our tongue retractor to kind of hold that gauze in place and keep the tongue out of the way too. Once again, just making like a little curtain or a little tent in that area so nothing can go posteriorly. Okay, now as far as forceps goes, what I recommend is probably you can take out just about any tooth in the mouth with these 5 forceps. Of course, now, being an oral surgeon, most of us can take out a tooth with anything you hand us, but I would say that we recommend 5 forceps now that you need to take out any particular tooth in the mouth. Okay, the upper anterior forcep. This is what an upper anterior forcep is. It's a straight upper. I like the forceps that have a little serrated beak at the end. You can see the beaks at the end is a little serration, and I like to use this forcep if I'm taking out any tooth from the second premolar on one side all the way across the anterior to the second premolar on the opposite side. So for these particular, let's see, 5, 10 teeth, I'll always use the upper anterior forcep. Okay, now the remaining teeth in the maxilla, let's see where there's a first molar, second molar, and third molar. I like an upper universal forcep for that. So these 2 particular forceps we can use for any particular tooth, taking out any tooth on the maxilla. It covers all bases. As far as the mandible goes, the Ash forcep, I like to use this particular forcep if I'm taking out a mandibular tooth, which goes from the second premolar on one side all the way across the anterior to the second premolar on the opposite side. Once again, all these teeth I use just an Ash forcep. And this is a great forcep. What we do is we tend to seat the forcep down, and this is a rotational type of forcep. We just tend to rotate mesial, distal, a little figure 8, and then the tooth usually comes out pretty nicely. Okay, rotational forcep. Okay, now as far as our mandibular molars go, our first molar, second molar, and third molar, I like to use the lower universal. And once again, I like the universal forceps that have those little serrated beaks at the end. It helps me sneak below my gingival tissues, and I get a good purchase on that tooth, less chance of fracturing the tooth on the way out. And of course, any tooth that has a frication in it, whether it's first molar, second molar, or so, I like to use a cow horn. Okay, cow horns, you can see there's a beak on both sides. One beak is set on the buccal tissues. One beak is set underneath the lingual tissues. Both beaks go into the frication. As you gently squeeze the handle together, you're kind of pumping that motion up and down, and it kind of displaces the tooth out of the socket. Okay, so let's go through our technique. What I do is whenever I take a tooth out, what I'm going to do is I'm going to think about how I'm going to remove this tooth ahead of time. So I'm going to think about, I'm going to make my flap. I'm going to start to do some elevating. I'm going to think about sectioning. I'm going to think about elevating again, and then what forceps I'm going to do to deliver the tooth. And I find that this plan allows me to preserve as much bone as possible. And now in the days of implant dentistry, that's the key. We want to preserve as much bone as possible. Let's try not to lift our periostomy up too much. unless we're making a big flap. Maybe if we need to remove some more bone, if we're doing some bone grafting, maybe some onlay grafting, let's try to keep our periosteal release just to maybe within 2 or 3 millimeters of the gingival margin. I'll show you my technique in a few minutes as well. Okay, so the key is to get a game plan. You know, I always say that if you're going to drive from New York to California, you're not just going to get in your car and just drive and see if you hit the right roads. You're going to pull out your GPS, you're going to pull out a map or so, and you're going to kind of plan your course. You're going to plan how it's going to be along that journey. And that's what I'd like to see you do in your mind before you go ahead and attempt any tooth. Just plan your journey. This way it helps prevent the unexpected. Or also think in terms of, okay, what happens if? What happens if I'm taking this tooth out and it might do this? What happens if I'm taking the tooth out and it might start to bleed? Think about all these what ifs. It just makes you a better surgeon. Okay, bite block. We always use a bite block in our practice as well. So I always tell the patient that, you know, instead of you having to keep your mouth open while I'm working and I'm moving your jaw back and forth, it's better if you take this bite block and we place it in the patient's mouth and have them bite down on that. And by them biting down on that, it creates a more comfortable movement. You know, the mandible wants to close as well as opposed to keeping it open. By biting down on it, also, it helps us control that force so that when I'm taking the tooth out, I want the only thing moving in this patient's mouth is the tooth. I don't want that patient's mouth moving back and forth. These bite blocks do come in different sizes. They come in a child, an adult, and an edentulous, and it's just really, really great. It helps prevent some soreness postoperatively, TMJ issues as well postoperatively. Okay, throat pack. We talked about the throat pack. Very, very important to make that throat curtain back there, so decreases the chance that anything can kind of jump behind the throat pack and go down the oropharynx. Okay, so as we say, do not take a tooth out. Do not do an implant. Do not use the screwdriver to place a cover screw. Do not use a screwdriver to place a gingival former without a throat pack in place. You can avoid a lot of heartache. Okay. Next, use instruments. We're doctors, we're surgeons here. We use instruments. Don't use your fingers. There's a couple times where I want you to use your fingers, and I'll cover that in a few seconds, but use the instruments that we have available. Less chance of damage and hurting yourself. Okay, now let's talk about what happens if. What happens if we're going to take the tooth out and all of a sudden you realize that, boom, you don't use the throat pack or your throat pack wasn't in a good position and that tooth just flips back and we kind of lose sight of the tooth. What happens? Well, where is it? Well, the first thing you want to do is you want to take a look around the patient's mouth. Maybe it fell underneath the flap that you're developing. Maybe it went underneath the patient's tongue. You know, maybe it moved itself into the buccal vestibule in the posterior. Just take a quick look around the patient's mouth. Let's say, God forbid, it goes beyond the or back in the oropharynx or further back. What you want to do is I'll talk about positioning of the implant, taking the teeth out in a second, but sit your patient up if you're lying the patient down. Reassure the patient that it will be okay. Make sure that maybe the patient has it. Maybe it's in the back of the throat and they can just hand it to you. Make sure that the patient's okay. Next, assess the patient. There's two places that this can be. It can either be in the trachea or the bronchi, or it can be in the stomach. So, you know, see if the patient has any difficulty breathing. If they do, it might be lodged right in the back. Maybe see if they can cough, see if you can suction it out, if you can see it, or it could be working itself further down, or it could be in the stomach. Okay, so what do? Well, this is an article that is actually written, and this is your flow chart. I want you to memorize this flow chart. There'll be a quiz later. No, I'm just kidding. Somebody wrote a journal article about what to do if somebody swallows a tooth. This is not necessary. Basically, what you do is you're going to make sure the patient's okay. You're going to assess the situation, see if there's a problem breathing or not. Maybe it's stuck in an airway or what have you. Either way, what you're going to do is you want to send that patient to the emergency room, okay? And what you're going to do is you're going to call ahead. Alrighty. Now, if your schedule is not crazy, if it's not really, really hectic, obviously you go with that patient to the emergency room. If you have a busy schedule, you have some patients ahead, what you want to do is then send a staff member with that patient and their family member to the emergency room. But you want to call ahead to the emergency room. Let them know who's coming in and what happened. Now, let's say you call ahead and you get the emergency room and they put you on with the emergency room doctor, and the emergency room doctor gets on the phone and he says, yeah, I'd love to help out, but I'm new, it's my first day. What do you want me to order? And you say, well, I'd like you to order, you know, you need to see if it's in the lungs or in the stomach. So, you know, you need to order a couple x-rays. Oh yeah, sure, what kind of x-rays do I need to order? Well, we should know, and we should be able to tell that emergency room doctor that we need a PA and a lateral chest radiograph and a flat plate of the abdomen. And hopefully between these three x-rays, we'll be able to discern, is it lodged in the lungs or is it into the stomach? Okay, so if it is in the lungs, what do? Well, probably in conjunction with ear, nose, and throat, we'll they'll schedule a bronchoscopy and they'll go inside and remove it out of the trachea or the bronchus. And of course, if you're thinking in terms of which bronchus can go into the right main stem or the left main stem, I'll pause for a second to let you think about that. And the answer typically is usually the right main stem, because the right main stem bronchus has more of a straighter path coming in from the trachea. Okay, now, if it's in the lungs, we do a bronchoscopy. If it's in the stomach, yep, you guessed it. The patient has to kind of monitor their stools for several days. Hopefully we can retrieve that. It's very, very important. Okay, so let's have some fun for a second. Knowing that it could be either in the lungs or the stomach, let's say that you are on a rotation in the emergency room and somebody comes in, they call ahead and they said, oh my God, my poor little child swallowed a coin. And where is it? Well, this is two different views on two different patients. There's two different children here. So the one on the left side, we see a circular object. That's the coin that the patient swallowed, and you can see it looks kind of like a ball. The one on the right side, it's a circular object, also a coin, and it looks flat like a disc. So the question I'm going to give to you all on the webinar now is, on the left side, is that in the trachea or the esophagus? And of course, on the right side, is that in the trachea or the esophagus? So take a few seconds and try to think about that. Try to figure out in each of the views where it might be. Okay, anybody have a guess? Okay, well, we know that the view on the left side is, since we can see the full circle, the full coin, it's probably lodged in the muscles of the esophagus. So you see how the muscles are kind of, striations kind of go from superior to inferior. They kind of create grooves, longitudinal grooves in the esophagus, and it's easy for that coin to get caught in the full position along one of those grooves. Whereas on the other view, when it's lying flat like a disc, a lot of times it will get caught just flat in between one of the rings of the trachea. Okay, so it's kind of cool. Okay, so let's go on with our technique now. Now we're giving some local anesthesia. We put our bite block in, we put our throat pack in. The next thing we're going to do now is position the patient. So what I like to do is, for my mandibular extractions, I like to put the lower jaw parallel to the floor. I like to, for my maxillary extractions, sometimes I treat the patient sitting up, and sometimes I'll just put the back of the chair back just a tiny bit. That's chair position. Now, vertical chair position. So typically we say is that if you're taking an upper tooth out, raise the chair up enough so maybe the patient's jaw is kind of at your shoulder, maybe a couple inches below your shoulder joint. And if it's a mandibular tooth, you know, kind of position the patient's chair position superior inferiorly based upon maybe your elbow. So you want to kind of around your elbow. So just be comfortable. It's very, very important that you are comfortable. As far as our operator position goes, if we're looking at the patient and the patient says, say the patient's in a dental chair, the patient's head maybe is at the 12 o'clock position, and let's say the feet are at the 6 o'clock position, we kind of want to be alongside that position if you're a right-handed operator, about the 8 or 9 o'clock position there. Okay, just a comfortable position. Of course, you're a lefty, it's the opposite. Okay, and what we want to do is use controlled, gentle forces. That's the key to taking teeth out. It's not roughing it out, it's not pushing out. That's when teeth break off, that's when roots separate. Just controlled forces. That's when soft tissue injuries occur and patients get upset. Nice and easy. Okay, what's my technique? Well, I like to be very efficient. I like to treat every single tooth the same way, and I'm always thinking in terms of, okay, if I'm going to be doing a bone graft here, this is what my procedure is. So first thing I'm going to do is I'm going to take a number 15 blade, and what I'm going to do is I'm going to incise the gingival tissues. So I'm going to go, if I'm looking at, say, tooth number 30, what I'll do is I'll incise the papilla mesial to this particular tooth. I'll just go intrasulcularly with my blade around the papilla mesial to my tooth. Then I'll go continue intrasulcularly around the buccal of that tooth number 30, and then I'll also go intrasulcular around that distal papilla, and I'll do that all on the buccal. And then I'll do the same exact procedure on the lingual. Lift up a papilla, intrasulcular, lingual, and papilla. And then I take my periosteal elevator, and I'm just going to gently pick up the gingival tissue. So I'll pick up the papilla, I'll pick up my papilla, and just kind of connect them along the buccal tissues. I'll do the same on the lingual. And I lift up about 2 or 3 millimeters, and you'll see that why in a few minutes when we talk about socket grafting. Same procedure every single patient. Next, what I'd like to do next is I'd like to elevate the tooth, and we'll start elevating the tooth, starting getting some wiggling, some movement. Remember, keep in mind, you never want to take a tooth out that's not kind of elevating, not kind of moving, because once again, more of a chance that the crown could separate, more of a chance to break a root. Now, when we do elevate, when we start to elevate the teeth, what we're tending to do is we want to expand that tooth. We want to sever the periodontal ligament. We want to widen out that periodontal ligament space. Of course, because the wider that space is, the more of an area in which we can move that tooth before we deliver that tooth and extract the tooth. So we want to widen out that periodontal ligament space. Okay, so what do we do? Well, first we can use some elevators. Number two, this is a great burr by Brasseler that we use in our practice, and it's a diamond burr, and it tends to be very, very thin diamond burr, and we like to use this in the periodontal ligament space. So what we'll do here is pay particular attention where your anatomy is. You want to make sure you don't go too far inferiorly and hit the inferior alveolar nerve. You don't want to go too far superiorly if you're taking out a maxillary tooth into the sinus. Be careful of your lingual anatomy, your buccal anatomy, and just stay in the periodontal ligament space. Be careful of your adjacent teeth as well. So you're just going to go around this tooth for about 4 or 5 millimeters or so and just kind of widen out that periodontal ligament space. Once that widens out, you're more apt to be able to take the tooth out atraumatically. Okay, so now another trick that we do to widen out the periodontal ligament space is to use a piezo. And this is a piezo that we use in our practice too. And the principle of a piezo is that it's like an ultrasound. So you have these extraction tips. You want to enter into that periodontal ligament space at a 45-degree angle and just gently let the tip do the work. You want to kind of just let it go up and down and up and down and up and down. And once again, what it's doing now at a 45-degree angle, you're entering into the periodontal ligament space and you're kind of just severing those periodontal ligaments, severing that attachment. So here you can see we went across on the mesial, and now we're going across on the lingual, and then we're going to go across on the distal. And you can see as we're going down, you can see that tooth start to move. You can see as we're severing those ligaments, the tooth is starting to move, and it really apps for a gentle atraumatic extraction. Okay, this is great for roots as well, not only for just for teeth. And you can see it really loosens up pretty well. Okay. And then we're going to eventually elevate next. Okay, so the principle of elevators is just, it all goes back to simple machines. There's levers and wedges, just a simple machine principle. What we're going to do is just kind of use our levers to kind of gently elevate the tooth, and wedges, keep in mind the principle here is that if we put a wedge or something into that periodontal ligament space, two things can't occupy the space at the same time. If I take a wedge or a periotome or something and I kind of place it into the periodontal ligament space, if I'm gently forcing it down that periodontal ligament space, once again, two things can't occupy the space at the same time. That tooth has to be extruded from that socket. And these are the principles that we use when we work in oral surgery. Okay, so we're going to use straight elevator on most of our teeth when we start to elevate. Be very, very careful not to fulcrum off the adjacent teeth, crowns, and fillings that are there. And of course, we could use a straight periotome too, which we'll show you in a few minutes. Okay, finger position. If we take a straight elevator, what I'd like you to do is hold that straight elevator in your hand and slide your index finger down along the blade of that straight elevator for about a distance of maybe up to about 1 centimeter. So about 1 centimeter of that blade will extend down beyond your index finger. This way, as you're elevating this tooth and you're placing it between the tooth and the bone, remember we don't want to fulcrum off the adjacent teeth. When we place it against the into the periodontal ligament space between the tooth and the bone, we're gently going to elevate, a little bit mesial, a little bit distal. Okay, and this helps prevent that blade from going, the tip of the instrument from going where it shouldn't be. The next thing I would say is only okay to place your finger there is if I would also recommend you put your other finger from your other hand under the index finger on the lingual surface of this. So this way, if that blade of the straight elevator happens to slip, it's only going to go about 1 centimeter in, and it can only go into your finger as opposed to into the patient's tongue and lacerate an artery or so. Okay, once again, just gentle, controlled forces. Okay. Now, a couple of tricks I'd like to throw at you to give you a couple of meat things to take home, as we say, is that I like to use certain elevators depending upon what couple teeth we're taking out. A couple tricks. Okay, so upper third molars, especially partially erupted third molars, fully erupted third molars, we love to use these POTS elevators, P-O-T-T-S. Great for these type of teeth. Now, when you're elevating this tooth, you can see there's a concave part of this elevator and there's a convex part. Your concave part of this elevator, I want you to lie it gently across the tooth that you will be extracting. And just like when we were using with a straight elevator, it's a perpendicular force and we kind of elevated mesial and distal. In this particular case, with this elevator, you're actually going to put it into the embrasure space and then you're going to kind of gently elevate and kind of push the elevator in between the embrasure space. And here what you're doing is as you're twisting and gently pushing your elevator in, you're actually going to be pushing downward and backward. So instead of just perpendicularly, this is a downward and backward movement. Put your throat back in, elevate downward and backward, and that forces that tooth out distobuccally. And this is a great elevator. Just like there's a one for the left side, of course, there's one for the right side as well. Okay, Potts elevators, very, very good for upper erupted or partially erupted third molars. Okay, of course, with single rooted teeth, double rooted teeth, it comes out a lot easier than multi-rooted teeth. Okay, another trick for maxillary erupted third molars. This is like a spoon, a larger spoon elevator. And here we want to come in at an angle. Sometimes I'll kind of flip it in a little bit more perpendicular. Same thing, get it into that embrasure space between the tooth and the bone. And this particular elevator does the same thing. It's kind of just like a rock from mesial to distal rock. Once again, the same thing, rock it and distal buckle, rock it and distal buckle. Throw it back in and then you take the tooth out. Okay. Mandibular erupted third molars. This is a great elevator for that. This is called the spade elevator. You can see it's shaped like a spade, like a shovel. And what you kind of want to do here, same thing, is kind of come in at a steeper angle between the tooth and the bone. And this is kind of the same thing. It's kind of like a superior elevation. Throw back in, you kind of wiggle the tooth, and you kind of just deliver it out buccally to a spade elevator. Okay, so here you can see here a spade elevator being used after we use that thin diamond burr. And you can see we kind of get right into that periodontal ligament space there. And once again, it's just kind of a mesial distal rock. Keep in mind that wedge principle. If we get our elevator gently down there, push and elevate, the tooth has to come out of that socket. Okay, other wedges, other elevators that we can use, these are called periotomes. These are great instruments too. I recommend getting a firm periotome. Don't get the flimsy ones that kind of break off and it's like use it for a couple times and all you wind up breaking off the tip and between the patient's embrasure. Just get a periotome that's a solid type of periotome. They make rounded tips, they make serrated tips, they make pointed tips, whatever works well on your hands. Once again, we're going to place this into the periodontal ligament space, widen out the periodontal ligament space, create some space into which we can move our tooth to be extracted. Okay, whenever we're dealing with roots, maybe we section off the top of the crown, which I'll show you in a few minutes, and we have some remaining roots, or a patient comes in with some residual root tips. We love these apexo elevators, and this is just, once again, a wedge type of movement. You kind of wedge it in and just rock the root out. Okay, everybody knows the east-west or cryo elevators. They come in large east-west and smaller east-west. The whole principle here is that you want to just kind of remove one of the roots and then take the other root and kind of push it into that embrasure space, that interradicular space where you just remove the other root. Okay, the east-west or cryo elevators. These are kind of essential elevators I think that you want to have in your surgical practice, and they help you taking out just about any tooth. Okay, so after we elevate our tooth now, as our tooth is moving, we don't want to take a tooth out that's not moving, then we use the appropriate forceps and gently remove the tooth. Now, a couple other tricks. Whenever we're thinking in terms of single-rooted teeth, as we said, the mandibular, second premolar, typically a single-rooted tooth, we're going to use our ash forceps. The ash forceps get seated, our beaks get seated down. I always like to seat my lingual first, make sure it's underneath the tissues, then seat my buccal, and then the ash forceps is just a rotation, a mesial distal rotation. Rotate back and forth, little figure eight, and eventually the tooth comes out. Maxillary single-rooted teeth. What I like to have you do here is use that upper straight forceps. Remember we said second premolar to second premolar, when we're taking out maxillary teeth, we can use a straight upper forceps. Same principle. I love these little serrated beaks. Sit it down on the lingual, the palatal, then sit it down on your buccal. Get as far apically as you can. I'd like you to take your other hand and I'd like you to pinch the maxilla. And what you'll be doing now is kind of just pinching the maxilla with your one hand, kind of seating those beaks. And now what I want you to do is I want you to rotate buccal lingually, rotate mesial distal and mesial distally. And what I want you to do is I want you to put traction on the tooth. So I want you to actually push apically as you're rotating mesial distal on the upper single-rooted tooth, and then you apply traction and take the tooth out. So once again, pinch the alveolus, seat the forceps. It's going to be rotate, but pushing apically. You're severing the periodontal ligament space, severing the periodontal ligament tissues, and then gently it's a traction and pull the tooth out. Okay, that's your maxillary extractions. Okay, multi-rooted teeth. Of course, the old adage is that let's divide and conquer. So if we try to take out a tooth that's shaped like an anchor, a maxillary first molar, it's going to be a nightmare trying to get that tooth out. If we section it up and treat them all as single-rooted teeth, it makes it all in our favor. Okay, once we section the teeth, use periotomes, piezo elevators to remove the roots. Just a word about surgical handpieces that, there's a lot of handpieces on the market. You can buy them overseas. You can buy them in reputable companies. They run the gamut in price. Be really careful of knockoffs or so, because you want to make sure that you have a surgical handpiece. What does that mean? That means that if you have a handpiece and you're holding the handpiece in your hand, the burr is on one end and the tubing is on the other, The water is the only thing that comes out where the burr is. You don't want air coming out of that front part. So water comes out the front and air comes out the back. Okay, this is a surgical handpiece. Problems can arise if air and water come out the front, and you can get what we call subcutaneous air emphysema. Pretty rare, but it can happen. And the tissues just kind of all swell up. It kind of has that crepitous feel. How do we treat it? Typically it's done, we usually refer to the emergency room. It's usually treated by steroids, some antibiotics, some pain medicines. And keep in mind, you don't want to compress these tissues. You don't want to push them out because it just helps spread that air underneath the tissues, okay? All right, so once again, getting back to taking out the multi-rooted teeth, this is a mandibular molar technique. Of course, we're going to section right through the furcation, buccal to lingually, and then we're going to treat it as two separate single-rooted teeth when we take it out. Okay, section the tooth, remove the distal root, and then remove the mesial root. Okay, maxillary molars, what we're going to do here, we're going to section starting on the buccal through the furcation, go about right to the central groove, and then kind of veer off to the distal and veer off to the mesial, and we section like a peace sign. What are we doing? We're sectioning off 3 of the individual roots there and then treat them individually, divide and conquer. Okay, so here's a picture from a friend of mine gave me this picture here. We're taking off the crown. You can see fistula on the buccal. This is a great picture because you can see the 3 roots where the 3 root canals are. We're going to section from buccal through the furcation down to the central groove. We veer off to the mesial, veer off to the distal, section like a peace sign, take out each root individually, preserving the bone quite nicely. Okay, so this is a little video that we kind of made up, and it shows extracting a first molar. So the thing is the first thing you want to do is just section the crown off. You know, I always say you don't get style points by ripping that tooth out in one piece. You know, it's all about being atraumatic extractions. It's all about preserving that bone, especially if you're thinking in terms of implant dentistry. So the first thing we're going to do is just section off the crown. I like to section right below, right into the CEJ area, remove the crown, and then just section the roots up in individual parts, as we just described in the previous slides. And you create like a peace sign. And once the peace sign is done, you're just going to start sectioning out those roots individually. Okay, and this is a nice little quick 2-second video which shows you how to section out the roots. And then you can see you using the appropriate elevators to actually remove each of the roots. This is a periotome we like. It's a pointed tip periotome. You see, just gently work those roots around. Use the space that you kind of created when you were sectioning to elevate your roots into. Okay, and just take your time and just kind of elevate those roots up. Okay. All righty. Next, once the tooth comes out, always check the bottom of the root for the root tip. Kind of embarrassing, especially being a specialist, if you send a patient to us and we send the patient back to you, and then about 4 months later you see there's a root tip left in there. So always check the root tip. You know, do you have to remove every single root tip? Of course, if it's in close proximity to the nerve or the sinus, and there's a risk that you can possibly push them into these structures, you know, just inform the patient ahead of time that this might happen, and then, you know, you're covering yourself as well. Okay, so just make sure the root tip is removed. If not, remove it. Okay, we want to remove the granulation tissue. We recommend too is that just really aggressively curating out that socket and just remove all that soft tissue, that granulomatous tissue, any infected radicular tissue that's down there. Watch out for the structures that the vital anatomy there. Obviously, don't be too aggressive if the nerve is down below or the sinus is up above. Irrigate, 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 and then irrigate again. This is going to save you a lot of problems with postoperative infections. Very important. Socket preservation, we'll talk about that in a few minutes. Suturing, that's another lecture we can do in the future. Postoperative instructions, typically what we do is we have all our instructions printed out. We go over the instructions with our patient. We give a copy to the patient, or if the patient has sedation, we give it to the family member who comes with the patient. We also have them put on our website. And of course, it's typically, you know, no rinsing or spitting or sucking through a straw, no smoking. We tell them don't wipe or spit anything out. Just kind of bite on the gauze. We always say take 2 pieces of gauze, fold it in half, half again, place it in the space that you can feel with your tongue there, bite down hard. You want to have as much gauze as possible in your mouth so that when you do bite down, it's hard to get your front teeth to touch. Swallow anything that's in there. Don't wipe or spit it out because you could potentially dislodge the clot. Typical structures like that. We always have soft diet for the first day. Once again, no rinsing or spitting or smoking. The following day, just business as usual, anything they want. We don't have them brushing their teeth at all for the first 24 hours. Antibiotics and pain medicines, how long? This is something that's new in our literature where it's the last few years. They recommend antibiotics now only if there's an infection or some degree of inflammation. If you are going to give antibiotics, probably only necessary to give about 3-4 days or so. Diabetics, we routinely cover for a week postoperatively. Anybody who's immunocompromised as well. Anybody with an active infection gets it for a week also. Pain medicine, nowadays in our practice, we're kind of going away. We're going non-narcotic. We recommend 2 Advil, 2 hours later, 2 Tylenol, 2 hours later, 2 Advil, 2 hours later, 2 Tylenol, 2, 2, 2, 2, 2, 2. And we find that this gives just as much relief as the narcotic preparations. There is a new medication that's out on the market now that has Advil and I should say ibuprofen and acetaminophen in one preparation, and that's available as well. Okay, so there's a little video and stuff. It's very funny. This reminds me of Brooklyn. Let's see here. Whoop. Kind of a cutthroat here to get those potato chips, but he's very happy because he thinks he's got the thing, but she's got the last laugh there. Okay, cute. All right, so that's the first part of our webinar tonight, and that's on extraction, atraumatic extraction techniques. Now what I'd like to do in the remaining time that we have together is to talk about basics of socket grafting. And of course, both of these topics are full day courses that we typically give at our educational facility, but it's really nice to be able to expose everybody and share this information if we can tonight. And then we'll have some questions, time for some questions as well. So basics of extraction grafting. So when we're talking about this, we're talking about what is extraction site grafting or socket preservation. Well, typically it's just the placement of different types of materials within the sockets alone with barrier membranes that maintains the socket anatomy or creates the missing socket anatomy that we once had. All in preparation possibly for making good crown and bridges, having a good dental anatomy, or placing implants. Okay, so then the question is should we bone graft everyone? And of course the answer is, well, in the literature it shows us that if you don't graft the socket, you could potentially lose up to 40% of that socket width within the first year and additional 25% in the second year. Some other studies that show similarly that you can lose about a millimeter of vertical bone loss within the first several months and up to 4 to 6 millimeters of buccal lingual width within the first 3 months. So the answer is, do we need to bone graft everybody? No, but literature shows us that it sure helps. But there's some indications when we graft and when we don't. We'll cover those in a few seconds. Okay, so once again, we already went through the basics of good socket preservation. Good socket grafting is extraction technique. You want good diagnosis, proper pre-planning, have a plan in which we want to do, and like we talked about, having a roadmap before you travel. It starts with atraumatic extraction techniques. Okay, once again, we talked about this before, seating your tissue, your beaks below your tissues on the lingual, the palatal, and the buccal, making sure you support the alveolus. And it's a apical pressure here, and then gently traction and rotation. We take the tooth out. Okay, atraumatic extraction techniques. Nice and easy, less chance of swelling, less chance of discomfort for our patients. Okay, we talked about that. Okay, treat the socket. Okay, very, very important. We mentioned before, it's very important to curette out all the disease and granulation tissues from the socket, pay attention to our anatomy, and irrigate a lot. Okay, we want to get all that diseased tissue out of there. It's very important. Another reason for that is helps prevent infection. And another reason also is that, if we place bone in that socket, our bone wants to adhere to good living bone, not to pathological tissues. Okay, the key for socket grafting is a blood supply. We need a blood supply. This is really important. A lot of times we'll take out, say, an upper first molar, upper first premolar, lower second premolar. You take the tooth out, there's no bleeding, and you say to the patient, oh, you hardly bled at all, I'll see you later. Those are the particular patients that might be prone to developing dry socket. Those are the patients that might have an extended postoperative the course that we have to deal with. You need blood supply. If you take a tooth out, you don't have blood supply, establish bleeding points. Take a quarter round burr, go into the lamina dura, pay attention again for surrounding anatomy. You don't want to go by the nerves or sinuses. Watch the roots of the adjacent teeth, but develop bleeding points. We need bleeding bone. Okay, then we're going to think in terms of packing the socket. So then the question becomes, well, what materials do we use? Well, there's different types of grafting materials that we have available to us. Okay, and each grafting material that we have falls into one of these 4 categories. Okay, and we'll talk about these in a second. Each particular grafting material we choose usually shows and works and functions in one of these 3 different ways. The bone grafting material we use is either osteoconductive, which in other words, it allows bone growth to come through. I give the analogy on this one, if you're into planting bushes and trees in the backyard, if you want to put grow a rose bush, you put a lattice against the back of your house, that rose bush will grow through the lattice. That's osteoconductive. It allows the growth of bone to go through that area. Osteoinductive, we're actually inducing, we're getting new bone cells to come into the area to form new bone. And osteogenesis, is the transfer of live cells from one area to the second area. Okay, so let's go through those 4 different types of categories of bone. Autogenous is, as we say, is the patient's own bone. It's the gold standard. We can get it from extraction sites in adjacent areas, trephinating areas in the bone, patient's own blood products as well. There's different instruments and materials that are out there to help us cultivate some of the patient's own bone. Okay, next, blood products, PRF, PRP, really, really big in our literature nowadays, also helps us in packing our bone and creating socket grafting. Okay, the mechanisms of bone growth, just to be complete, phase 1 is your osteogenesis part. We have some surviving cells that will proliferate. Phase 2, we have BMPs released. This typically happens over a couple weeks to about a month, a couple months, and this is the osteoinductive phase. Bone cells are coming in and forming new bone matrix. Phase 3 is the osteoconduction phase, where we have this inorganic matrix that we're just kind of forming in phase 2, and that's kind of replaced now by through a process called creeping substitution, where we're replacing with a new bone from the patient's body. And phase 4, we're getting the actual development of that solid bone. Okay, so next category we talked about autogenous, now is allogeneic. There's 2 different types of bone preparations for allogeneic. There's cortical and cancellous type of bones, and 2 preparations. There's mineralized and demineralized. Okay. Mineralized bone, it's cadaver bone, of course, and what happens is that this particular bone is processed, it's harvested from a cadaver. The way in which it's processed, it's washed in distilled water, ground down to certain particle sizes. They immerse it in 100% ethanol. They freeze dry it in nitrogen. And they grind it into smaller particles. Then it's sterilized through a process of irradiation or ethylene oxide sterilization. And this kind of gets the product ready for us. It gets rid of all the products and just leaves the bone that we need to use. Demineralized bone, we take that same bone and we put it through another step where we treat it with nitric acid, demineralize the bone. Here what we're actually doing is removing the calcium and phosphorus salts. We're almost creating like a collagen-based material, decreased antigenicity, and a very, very good product as well. It seems like we were kind of moving away from demineralized bone. Years ago, we were more into demineralized. Now we tend to be more in mineralized bone. Next, we have to think in terms of, do we want cortical bone or cancellous bone? So our cortical bone tends to be a little bit slower resorbing than our cancellous bone. Mineralized bone tends to be a little slower resorbing than demineralized bone. And the best particle size tends to be about 200 to 1,000 microns. So all these factors need to factor into place when we determine what kind of bone graft we're going to use. Now, I'm big about, like, what do I use? The why. I'm big about, whenever I talk about anything, any type of products, any techniques, I'm also about why. So I don't want to hear, if I ask you a question like, why do you use this particular product? Oh, the rep is really nice. The rep is service us. I had a good special. It was cheap. No, you want to know why. So whenever I'm asked this question, I use a 50-50 percentage of my bone grafts. I use 50% cortical bone, 50% cancellous bone. Reason being is that my cortical bone will kind of preserve my anatomy. It holds my space available when I'm kind of hoping that bone will grow through it, because it tends to be a slower resorbing process. My cancellous bone, the other 50%, is that it's really good to pack in that bone material. This allows a faster ingrowth of bone. So the cortical bone will maintain my space, because it's so important to maintain my space to develop my bone graft. The cancellous bone maintains the space and allows the blood vessels and other bone cells to grow in there. It gives me strength. I like a particle size of about 200 to about 1,000 microns. Okay, other materials that we talked about was alloplast. This is a synthetic bone substitute like calcium sulfate. And lastly, the xenograft. We like the component, the bovine bone component too. We'll probably use this most of the time when we're doing our sinus grafts. This is it's probably out of all the materials that we just spoke about, the slowest resorbing. And I use this for that reason when I place my sinuses. I want to make sure that I maintain that space for a long period of time. Okay, so now, what type of material do you choose to use? It depends on the type of defect that you have and what you need it to do. So most of the time, if we look at socket grafts, we're going to talk about the different types of sockets. There's a type 1, 2, and 3 socket. So type 1 sockets are where you really have a buccal plate that's intact and kind of thicker than about 1.5 millimeters and 2 millimeters of bone. Okay. So once again, do we graft every single socket? No, we don't. These sockets we do not graft. So type 1 sockets, which have bone greater than 2 millimeters or so, we don't graft these sockets. It's not necessary. If you're thinking in terms of a type 2 socket, where maybe now the buccal plate is there, but it's thinner than about 1.5 millimeters, or in type 3 sockets where the buccal plate might be missing or fractured, those 2 sockets are the ones that we're going to graft. And we show that those in the literature shows that we get the best chance for maintaining or actually growing horizontal bone. Okay, so of course, when you're talking in terms of socket defects, We're talking in terms of bony wall defects, and the way in which this works, 5-wall, 4-wall, 3-wall, 2. These are the remaining bony walls that we have. Okay, quite confusing, but once you understand the concept, it's fine. We're going to be grafting these 4 or 5-wall bony defects in this technique I'm going to show you now. So with the 4 or 5-wall defect, maybe all the walls are intact, or maybe one is missing, or one is very, very thin, under 1.5 millimeters. Okay, 5-wall defect, once again, all 5 walls are there. Okay, you have the lingual wall, the buccal wall, mesial distal walls, and the inferior wall. Okay, 4-wall defect, one of those walls is missing. Okay, and then the question then becomes, do we place a membrane or not? Well, the role of the membrane is that whenever we take a tooth out, the socket heals like a V from the bottom up very, very slowly, and from the top in from the gum at the same time. So what we want to do is we want to kind of hopefully let that bone grow from the bottom up and help prevent against that soft tissue growing in from the top. And that's the purpose of a membrane. If we take a tooth out, place a membrane on the top of that socket, hopefully we allow all the bone to grow from the bottom up and prevent all that soft tissue growing in from the top down. Now, membranes, if we decide to do a membrane, what material do we use? Well, we know that there's resorbable and non-resorbable membranes. So resorbable membranes, the drawback here, I would say, or the quality of resorbable membranes is that they must be covered by tissue. So you need primary closure here. Examples of the resorbable membranes, they're collagen-based materials. Typically, they come either non-cross-linked or cross-linked, which means that they're chemically treated just to slow down the breakdown. And you can see a couple examples here. The drawback, once again, is that you might need a secondary procedure to increase the attached gingiva. And what I mean by that, think about that first molar, mandibular first molar you took out. Typically, they might have, say, a 0.5 millimeter or 1 millimeter of attached tissue on the area on the buccal. You take the tooth out, you do your socket graft, you place your resorbable membrane. What do you do with that buccal tissue? Well, we said we need primary closure. You typically wind up taking that buccal tissue and kind of pulling it all the way to the lingual. What did you do to that millimeter or millimeter half a millimeter of attached gingiva? You just pulled it all the way over to the lingual. So now literature shows us is that whenever we're doing dental implants, we need a minimum of 2 millimeters of attached or keratinized tissue on your buccal. So if we need to do that, we might have to take our, if we do a second stage procedure, or when we're ready to place our implant, we might have to make our incision site, instead of crestally across the top of the crest, we might have to cheat a little bit way lingual, which could jeopardize the chance of maybe getting into a lingual nerve or so. Or what we do is we need a secondary soft tissue grafting procedure. Okay, so what I typically recommend is a non-resorbable membrane. And the beauty of a non-resorbable membrane, and the one we recommend is a PTFE membrane, is that here, what we have to do here is when we place our bone graft, we don't need primary closure. We don't need primary closure, okay? And the beauty of this is that you use this non-resorbable membrane, you take your tooth out, you pack your bone, you place your non-resorbable membrane, and then once again, within about a month or so, you remove the membrane, and then what it looks like underneath there is you get this reddish looking type of tissue, and that whole band is going to fill in now with attached gingival tissues. So let's think in terms of that mandibular molar that has that 0.5 millimeter or 1 millimeter of attached tissue, as we said before. Let's think in terms now, taking the tooth out, packing our socket, instead of pulling that tissue all the way, that buccal tissue all the way to the lingual, we just leave the buccal tissues where they are. We place our bone graft, place our resorbable membrane, non-resorbable membrane over the top. We don't get primary closure. And what happens now is that over the month or so, then we remove our membrane, and then we just generated a whole big band of thick tissue. And I'll show you what that looks like in a second. Okay, just as an aside, keep your armamentarium nice and clean and neat. It's a reflection upon you as a surgeon and what we do. So this is a technique taking through a patient. So this is a true case that we did. So you can see here, the first thing is that this is my typical technique. I'll take my number 15 blade, lift up my papilla on the mesial to the tooth that we're taking out. We go intracircularly. Then I'll pick up the papilla distal to the tooth we're taking out with the blade. And then I'll come in there with my periosteal elevator. I'll take my sharp edge, lift up my papilla, and then I'll switch to my rounded edge and kind of connect the two and lift up a little bit more. Once again, I'm lifting up to about 2 or 3 millimeters of tissue. I do on the buccal, and then I do it on the lingual. We'll elevate the tissues. Of course, here we need our throat pack. We start to elevate our teeth, and we do that gently across that area. This is a gentleman who actually had radiation. He had some hyperbaric, and we decided to take his teeth out. we decided we were going to do a full arch on this particular person, and we went ahead and took the teeth out a couple at a time because we were worried about osteonecrosis. We did some bone grafting, we made a denture temporary. It turned out to be really good, and he didn't need to come back to do the full arch. But once again, here's our ash forceps. We seat our lingual tissue to our buccal, and it's just a rocking mesial distal figure 8 motion. We take it out. Okay, remove any disease or granulation tissues that we have, just free any type of necrotic tissue, purplish tissue, anything that just doesn't look healthy, we remove that. Okay, and then we're going to go ahead and gently curette our sockets. Watch out for a regional anatomy there. Remove all that fibrous tissue, the granulomatous tissue. Okay, and then what we like to do is that, remember we said that we're going to lift up 2 or 3 millimeters on the buccal and 2 or 3 millimeters on the lingual. The purpose of that is you're creating a little bit of a pouch into which you can place this non-resorbable membrane. I typically like to place it a little bit on the lingual first, and then what I'll do is we have bone carriers and pluggers that we only use for bone. They're amalgam carriers and stuff, we only use them for bone. And what we do is we start packing that bone inside it. We talked about the placement of the membrane already. We're going to pack up some bone, and then we're going to place that into the socket. And you just kind of use a layered approach, like most of the time when you're making composite restorations, you do a couple layers and cure it. Here we just put in our bone, we tamp it down, kind of compress it a little bit there, and we're going to do that same procedure all the way up, pack up some more bone, and place it in the socket. And just kind of gently keep adding that along the way. We're tamping it down. And we keep doing that, and we tend to want to overbulk it, overfill it a little bit. The question then becomes, like, how do we tamp it down? How hard do we push down there? Well, you want to compress it so that it almost has like an Italian ice type of consistency, and you're able to take your periodontal probe and kind of gently push it through that bone. Okay, you don't want to have to force it through, and yet you also just don't want it to fall through quite easily. You overbulk a little bit, and then we're going to pick up the buccal tissues. We're going to tamp down our membrane, kind of tuck it underneath there, and then we're going to place our figure 8 sutures. I'll show you the suturing technique that we like to use. We like to use a modified figure 8. What we do here is that we're going to leave the sutures in for 2 weeks. We remove them at the 2-week mark, and then 2 more weeks after that, we remove the non-resorbable membrane. And you don't need any local anesthesia at all. You kind of just take a tissue pickups and just kind of gently remove it from the tissue. And this is what it looks like when it's removed. So when you remove it, you might have little pieces of granulation tissue in there, like pieces of bone or so that just kind of work themselves out. But you can see that this whole thing is going to fill into a huge thick band of attached tissue. Very predictable horizontal bone growth, very predictable huge band of keratinized tissue in which we can place our implants. Set yourselves up for success. Okay, now socket preservation. How long do you wait until you place your implant? Well, typically it's about 3 or 4 months, depending upon your bone substitute you use. Depends upon the root size, tooth number of teeth, size of the teeth. Okay, and this is our materials list. We always recommend, once again, we set up a needle holder, suture scissor, pickups with teeth. We like the PTFE sutures, dense PTFE membranes, your bone material, pluggers, bone pluggers, and bone carriers. And last few slides, and then we'll get to some questions. We like this size PTFE membrane. We tend to contour these all the same way. We do like an hourglass approach first. We do a buccal hourglass, a lingual hourglass, then we kind of take a little part off the front and the back on the mesial and the distal, create little tabs there, and that's how we kind of tuck it under the tissue. So here shows that contoured membrane. We kind of tuck it underneath the lingual first. You mix up your bone, place your bone, overbulk a little bit, tuck in your membrane. And this is the suturing technique I'd like you all to try if you don't mind. It's a modified figure 8, and it really helps take those tissues and really kind of puts it over the top of that membrane. So what I like to do here is I like to go on the mesial lingual first. You can see we're kind of doing like an inside out suture. We're taking the curve of the needle, we're entering into the tissues from the lingual part of that lingual tissue. You go from the socket, from within the socket out, and that's on mesial lingual first. And then we're going to do our buccal, mesial buccal second. Once again, all our passes come from within the socket and go in and then out. So we did mesial lingual first, then we do mesial buccal. Now we're going to go from within the socket, distal lingual, and we're going to go from within the socket, distal buccal, and we come out and we tie our sutures off, and remember to square the knot, and we get a nice knot there. So this is a great suture that we use it really tends to help take the tissues and really kind of pull them over the top of our membranes. Okay, so here we go. If we do have say we're missing a buccal plate here, maybe a 4-wall defect, A lot of times we'll place a resorbable membrane on that buccal defect and pack our bone against that membrane, and then we'll place another non-resorbable membrane over the top of that membrane, and then we loop it underneath the lingual, as we said, underneath the lingual tissues. So here you can see we're doing that modified figure 8 where we're pulling the tissues and kind of pulling it over the top of the membrane. And this is really, it's kind of a neat stitch to do, and it kind of really holds that tissue down for you. Okay. Okay. Once again, remember to square your knots too. I think that's the key to a good surgeon. It's just taking your time. Square your knots. Less chance that your knots are going to slip. And remember, patients judge us on how we do as far as pain. As long as we don't hurt them, they like us. And we could tell as surgeons, though, if we're looking at somebody else's knots, take your time. Make sure your knots are not placed over the sockets. Pull them off to the buckle. Keep them away from the lingual, because people tend to play with them a lot on the lingual there. And just take your time and space your knots nicely and evenly. Equidistance from the wound to the buccal or the lingual, and equidistance from the superior to the inferior. And you can see here we are tying off that knot. Okay. All right, last slide coming up. And I think the benefits of the non-resorbable membrane is that you don't need primary closure. And I think that's a big part about what we do. Less chance of some discomfort for our patients. We don't need to get that primary closure. It can be exposed to the oral cavity. It's a big plus for us. Very easy to remove. Sutures come out in 2 weeks. The membrane is removed in a month. And it just generates that thick band of keratinized tissue and some really good bone within 3 or 4 months that we could place our implants into. Okay, so just finishing up now, and we could entertain some questions. So I know that Joyce has been fielding some questions, and I'm going to turn it back over to Joyce and see if she has any questions for us.
Wonderful. Thank you, Dr. Silverman. Ladies and gentlemen, this concludes the presentation.